Good afternoon, everyone. Welcome to Monday Echo Session. And this time, we will be talking about sexual and gender-based violence, a very topical issue in our current scenario where we have quite a number of cases being reported from various provinces across the country. And we actually do know that SGBV is one of the drivers for HIV. And we thought it would be very, very ideal to have such an important topic being shared with the network this afternoon. So thank you very much, network, for joining us. I know we still have a few more people that are yet to join us. We are just about 156. Ordinarily, we would actually recognize everyone on the call, but because we're too many to take us the whole hour, we'll just acknowledge you generally and just say thank you for joining us today. So remember, echo etiquette to always mute yourself, always raise your hand if you want to say something. And if you can keep your camera on, keep it on. But if you're struggling with internet and your bandwidth, you can just put it off. And this afternoon, I'm joined in the hub by a very able presenter and an expert on this topic, Dr. Bupe Musonda. She's going to just say hello and maybe just say hello to the network.
Good afternoon, everyone.
Yeah, thank you very much. And I've also been joined in the hub by Dr. Muhumu. He will be my co-facilitator for this afternoon. So we also have Sister Evelyn and Sister Makupe here that have joined us. We have our IT and we have got now Dr. Muhumu who will be our co-facilitator for this afternoon session. So thank you very much, everyone, for joining us. Muhuma. Apologies for that. So without further ado, I will just quickly invite Dr. Musonda to introduce herself and go on into presenting the session for today. Dr. Musonda.
Good afternoon, everyone, once again, and thank you for joining us. I'm glad and feel privileged and honored to be invited to the platform to share a topic that I'm very passionate about. And I hope you will, at the end of this session, you will all share in this passion with me. I am one of the trainers and mentors in SGBV, particularly in child sexual abuse and also sexual violence against children. My other role is that I am the HIV prevention advisor at the Ministry of Health. So I'll take you through the presentation. Our objectives for this session are to explain sexual gender-based violence, its types, forms, signs, and consequences. I'll also take you through some statistics to make you appreciate the Zambian context of SGBV. I will also want you to understand the role of healthcare providers in the SGBV response, and also to become acquainted with the basic medical management of SGBV cases. We will also end the discussion by discussing challenges with SGBV programming and outline recommendations for these challenges.
Thank you so much. I'll ask Dr. Muhumu to run us through the poll questions. Dr. Muhumu, kindly pick it up. Muhuma, sorry.
All right, thank you, Dr. Kozia, and thank you so much for this opportunity. So our first poll question is a true or false question. It reads, sexual gender-based violence is any act of a sexual nature when consent is not obtained or not freely given and involving all forms of intercourse. I'll read that again. Sexual gender-based violence is any act of a sexual nature when consent is not obtained or not freely given and involving all forms of intercourse. True or false? We have about a minute to tackle this question. I can see people are polling. We have just over 200 connections, and then just about 130 have called so far. Interesting answers. Question 1 is a true or false question. True or false? Sexual gender-based violence is any act of a sexual nature when consent is not obtained or not freely given and involving all forms of intercourse. I think we have a good number of people who have polled so far. We'll end the poll here and then we'll continue with the presentation.
Very interesting answers indeed. Okay, so the first thing will be to take you through some definitions. So what is gender-based violence? I think we all use it in jokes, in definition, in our work, but I think it's important to understand the definition and what it entails. So this is an umbrella term used for any harmful act that is perpetrated against a person's will or a threat of such an act, and depriving freedom that is based on socially ascribed differences between males and females, i.e. their gender. So any act of violence against somebody due to their gender. And there are different types of GBV that exist, namely physical GBV, psychological, which we also call emotional, domestic and family violence, neglect, and sexual, which is what will take up today's presentation. So what is sexual GBV? It's any act of a sexual nature, contact and non-contact, causing discomfort or harm to a person based on their gender, resulting in a myriad of negative effects. So we see here that sexual GBV is not only limited, the next slide, fine, thank you, is not only limited to intercourse, but it also includes other forms such as inappropriate touch, which we call groping, all forms of penetrative sex, insertion into the private parts by any object, voyeurism, which is the love or affiliation to spy on naked people, exhibitionism, showing your private parts to an unsuspecting person, involvement in sexual activities, which can involve pornography, videos, and sexting, which has become quite common in the younger generation of late, knowledge of sexual behavior inappropriate for a child's age. This is particular to child sexual abuse. So any knowledge of sexual behavior or sexual information that is inappropriate for a child's age is also considered sexual GBV. And of course, forced prostitution. There are other terms that we need to be aware of that we sometimes interchange and use. So I just thought that we should bring them out and make them clear. We also have sexual violence, which refers to sexual activity when consent is not obtained and not freely given. Examples of such are the rape and defilement, forced sterilization, forced abortion, forced marriage, female genital mutilation, and virginity tests. So this is sexual violence. And for sexual assault and abuse, these are more police terms, but most of us health workers often use them and also put them in our impressions after seeing a patient. So it's important to know that these are not medical terms, they're police or legal terms, but we also need to be wary of them. Sexual assault. This refers to an acute instance of sexual violence, often occurring within 72 hours. Whilst abuse refers to chronic assault, so repetitive sexual violence or repetitive sexual assault. So that is the difference between the two. And I hope that it will be made clear after this.
Okay. All right, we go to the second poll question, which is really a statement. Is this statement a myth or a fact? Child survivors of sexual assault or abuse will always present with abnormal examination findings. These statements always remind me of medical school. When you see the word always, what does that tell you? So is this a myth or a fact? Child survivors of sexual assault or abuse will always present with abnormal examination findings. So we have a minute to poll. You can see the answers are coming in really fast, which is good. About 100 people have polled so far out of the 265. We encourage you to answer the questions as this is a learning session so that we debunk these myths or indeed if they are facts. Child survivors of sexual assault or abuse will always present with abnormal examination findings. I can see a majority of people have polled. We have over 160, 170 now. Ten seconds. Child survivors of sexual assault or abuse will always present with abnormal examination findings, myth or fact. We'll end the poll at this point and we'll continue with the lesson.
Very interesting. Very interesting. So let's delve a bit into child sexual abuse. So we are looking at a revised definition of child sexual assault, which was revised in about 2002 by the WHO. And it reads that child sexual assault is an act in which a person intentionally sexually touches an underage child, usually under the years, under 16 years or 15 and below, regardless of whether that child's consent was given or one who coerces or physically forces a child to engage in a sexual act. So I'll repeat, child sexual assault is an act in which a person intentionally touches an underage child, regardless of whether that child's consent was given or coerces or physically forces a child to engage in a sexual act. So what is the importance of this definition and why was it revised? It has a medical legal intonation to it. So the significance is that it shows that when it comes to child sexual abuse, it is not only restricted to penetrative sexual activity or intercourse, but includes the non-contact sexual abuse, which often will not result in injury. So only penetrative sexual abuse has the potential to cause physical injury to the sexual organs. More often than not, we will see signs physically, but commonly will occur without injury. And this is because of the anatomy of the genitalia, especially mostly for the younger children, which have more blood vessels, which also perpetrate or make it easier for healing. So because of the increased vasculature to these organs, healing is faster. And then also because of the size, the proportions of the genitalia, more often than not, injury will be seen externally to the external part of the genitalia as opposed to the internal genitalia. So in other words, what we are saying is that absence of injury, physical injury on examination does not rule out assault or abuse. So this is important in the fact of the way we sign the police forms when we say it does not prove or I do not, or the results are not consistent. Now we know that when it comes to child abuse, it has a different intonation and the definition is a bit different. So when it comes to child sexual abuse, we know that it can be organized where there's multiple perpetrators or multiple victims or individual. When we look at statistics, we see that 12% of females and 8% of males will experience penetrative sexual assault, child sexual assault, whilst 16% of males and 36% of females will experience non-penetrative child sexual assault. This was proven by a study that was done by Price Robertson, Bromfield and Vassallo in 2010. So this proves that the most common type of sexual assault is actually non-penetrative. And who are most likely to abuse? I think we all know that mostly it's girls, but when it comes to disabled children, they are 7 times more likely to be abused as opposed to able children. And this is as reported to a study done by Briggs in 2006. Next slide, please. So let's look at the Zambian context. We bring it down to scale. I pulled out the GBV report from the Zambia Police Service for the 3rd quarter of 2020, where we saw that there were 7,640 GBV cases recorded in total, which was a 19.8% increase from Q3 2019, so from the previous year. And of all these GBV cases reported, 24% were seen in children, 58% in women, and 18% in men. And in all these GBV cases, 89% of the sexual GBV cases happened in girls. And when we go deeper, 74% of all the abused children were girls. So this is what the first one will look at the adult or generally girls, and then the second one will look at the abused children, defilement cases. So, and of the 714 defilement cases, we saw that 99% were girls. And as a result, we saw that there were 25 GBV related murders. So in as alarming as these numbers are, this is only for a quarter. So if we're seeing 714 cases in a quarter, what more for the whole year? And when we look at the distribution of these cases, we see that the bulk, 42%, are happening in Lusaka, followed by Central Province, and then Eastern Province, and Southern, and then the other provinces distribute equally. So when we go deep and look at these GBV cases reported, we will see that of the bulk of the cases reported to the police, 33% were occasional bodily harm, so basically physical assault. 20% were neglecting to provide. As we said, neglect is one of the forms of GBV. And then defilement is in 3rd place with 17%. So defilement actually is carrying quite a large percentage of the total cases reported. But if we look on the right side of the screen, it's quite disheartening to see the outcome of these cases that were reported. Of the 14,000 reported cases, only 1,247 were convicted. Half of those were withdrawn, and only like a 10th. And of those, a 10th were acquitted cases. So what is this showing? Why is this important? The conviction comes, if you discuss with the lawyers, they'll tell you that we have to prove beyond all reasonable doubt. But because our medical evidence isn't sufficient or is not conclusive, cases are thrown out and the perpetrators are let to go. Then communities, because of the way that we handle our cases, they're withdrawing. So this is what is significant about the information. Next slide. So when it comes especially to children, even in adolescents and in women, of course, it's not all cases that will come to your doorstep to the health facility and say, I have been abused. Some cases will be implied. Some will take the keen, observant eye of the clinical provider, of the healthcare provider to notice. So I just wanted us to look through briefly some of the signs that we see that will point towards abuse without it being inferred or without it being communicated. Obviously, we might see difficulty in walking, the gait, the altered gait, bloody torn underwear. We should ask questions. Bleeding or bruising in the genital areas should raise questions. But the one I wanted us to pay attention to, which most often than not we see and ignore in the health facilities, is someone who keeps appearing with frequent urinary tract infections or yeast infections. Most of us, if you look through the book, it's always continue, nystatin, UTI, the whole book, but we have not raised questions. Why do they keep coming in with infections? Is it surely a hygiene problem? It's a sign. It could be a sign of sexual abuse. Anyone who comes with a sexually transmitted infection, immediately we should think sexual abuse. Pregnancy. But sometimes it might just be behavior in our clients that make us see or think that they might be experiencing abuse. What are these? Regressive behavior. This is more common in children. A child who could read, who was performing well in school, starts to not do so well in school. They change, they start acting like a baby. These should be alarms to wonder what is going on. I already mentioned the inappropriate sexual knowledge. Inappropriate sexual behavior. I've seen cases where an 8-year-old girl is flirting with 50-year-old men, complimenting their ties, their suits, and their good looks. An 8-year-old girl. That is inappropriate sexual behavior. Nightmares, bedwetting. This I saw in my clinical practice. A lot of the children who were coming in with bedwetting, when you delve deeper, it was actually survivors of sexual assault. Large weight changes. I know this is a big thing in Zambia. It's supposed to be a compliment when people say, "Waina, wayonda, you've gained weight, you've lost weight," but it should be more than that for a clinician. We should think, why should somebody gain or lose weight or change their appetite? Suicidal attempts, people who shrink away or run away. But commonly I've seen in children is those who are overly protective or concerned for their siblings. You're attending to their sibling, but the other sibling is hovering over and wanting to protect. That should raise an alarm. Why are they being protective? What are they afraid of? Sometimes we will see common reactions. They will be withdrawing, depression. They'll have sleep and eating disorders, self-mutilation. A small study that was done in Lusaka showed that out of 10 adolescents, 6 are self-mutilating. And this is by slicing of the wrists, self-imposed tattoos, all because of sexual abuse. Phobias, as I mentioned, there might be school academic performance problems. Here is one that causes a lot of debate. Poor hygiene or excessive bathing. Most of us like to praise children who like to bath 5-6 times a day and think they're very clean. But sometimes that excessive bathing might be a manifestation of them trying to get rid of the trauma that they went through. So these things can cause alarm. Apart from that, we see anxiety, guilt, and fear. So these are just some common signs that we might see that should make us from here forth look at things differently and not take things so lightly. Next slide, please. As we see, GBV has a lot of consequences, both fatal ones, acute, chronic, reproductive, emotional and psychological, and social. I will concentrate more on HIV/AIDS, which is one of the consequences. How does GBV influence HIV/AIDS? It does so because of GBV. It could pose as a barrier to uptake some HIV prevention, testing, and care services because of the experience, maybe living with the perpetrator, being under the arms of the perpetrator. It could also inhibit one's ability to access these services or even disclose their status. And for those already on treatment, it could reduce their linkage to HIV care or even initiation to start treatment. So we see that GBV directly impacts HIV, and this is why GBV has been put as one of the focus areas for the HIV prevention program in Zambia. Next slide, please. So now that I've given you a bit too much information, it's time to jolt our brains a little bit.
Yes, it is. Thank you so much. So far, I think the presentation is really eye-opening, and it's a timely presentation. Question 3, also true or false statement. When a survivor of sexual gender-based violence presents to a health facility 72 hours after an ordeal, there are limited services to offer, including examination, HIV testing services, and counseling. I'll read that again. True or false? When a survivor of SGBV presents to a health facility 72 hours after an ordeal, there are limited services to offer, including examination, HTS, and counseling. We can go ahead and poll. So far, we still have under 100 that have polled out of the connections that we have. We have 1 minute.
It's interesting.
Wow, really interesting answers we're getting. "15 seconds. When a survivor of SGBV presents to a health facility 72 hours after an ordeal, there are limited services to offer, including examination, HTS, and counseling. True or false?" Dr. Bupe, please take us through.
Very interesting. So I think we can move on to the next part of our presentation, which is now focusing on the healthcare providers. What is the role of the healthcare providers? Where do we come in? First and foremost, we need to identify violence. In as much as we think it's easy, I think based on the signs that I've spoken about, some of us will realize that we ourselves have been perpetrators or have missed possible signs of violence. So the first thing is to identify the violence and then give an empathetic response. Why is this important? Because the minute we start to judge or offer our personal opinions, that is already trauma in itself. They've already been through enough. They're already blaming themselves. So now adding a judgmental response doesn't help. We've had health workers say things like, obviously you were raped, dressed like that. What did you expect? Didn't your mother teach you not to enter a man's house or a man's car? Things like that. That is not our place. Let's be empathetic. And in fact, we should congratulate them for coming forward, because it takes bravery and courage to actually report an incident, especially when it's coming from within a known circle. Obviously, there's clinical care and medical management, which is what we are destined and put here to be. But I'd like to focus our attention on appropriate referrals. What do we mean by appropriate? It's not enough to just say, I'm sending them for counseling. What kind of counseling? What we need is trauma-focused behavioral counseling. So we have to attend to the trauma they're dealing with. Are they blaming themselves? Do they feel like going on with life? And then if it's children who are involved in sexual activity, behavioral counseling. Why are they involving in these activities? So that's what we mean. And then also cervical cancer screening, which very rarely most of us think of. We should refer our clients, not just for testing, but also for cervical cancer screening, looking at the prevalence we have in Zambia. So let's make appropriate referrals. Our role is also to provide medical legal evidence. This is by documentation. I want us to understand that when we document our examination findings, the main reason for this is to assist the court in reconstructing the events. More often than not, people will forget the events or they'll change the story as time goes, especially as the trauma slowly goes down. So our job is to help reconstruct by putting in a full history and our examination findings. One thing that our documentation cannot do is determine whether there was sexual intercourse or there was sexual assault. More often than not, we'll find the lawyers saying, so with your findings, can you say that sex happened or there was sexual intercourse? And you say, yes, I can definitely say that. You've already lost the case because you had to be there physically to see that it happened or have other evidence, corroborative evidence to back up. Ours is just to show that there was sexual injury or not, and to determine whether there were surgical or medical complications and help reconstruct events. That is what our documentation is for, and that's all. What you are not responsible for is to solve all the violence-related issues. This is why we advocate for multidisciplinary management of GBV. There's a role for the police, there's a role for the legal advisors, there's a role for the medical advisors, there's a role for the psychosocial counselors, and there's a role for the community as well. So let's not try and be heroes and be Robin Hood and do everything, put everything under our belt. It is impossible. We cannot address all the violence-related needs, and you cannot offer all the treatment. You cannot be the one doing the cancer screening, the PEP, everything else. That's why we all have different roles to play in the clinic. And that's why in the concept of one-stop centers, this is why we have different experts to handle different aspects of GBV. Next slide, please. So what then is the minimum package for services for post-violence care? The first thing is counseling, which I already spoke about. This should be the first entry point. Before we do anything, we should counsel so that we prepare them for what's about to happen, including the medical examination. Before we rush to do the genital examination, let's treat the acute injuries, any life-threatening injuries. After that, we do STI screening and treatment. Then we can do rapid HIV testing and more counseling. And then we administer PEP, post-exposure prophylaxis, if the client has appeared within 72 hours. And we know that PEP is taken for 28 days. We do a pregnancy test, and if it comes out negative, we offer emergency contraception. And this is if the person should arrive within 120 hours. After that, we should make appropriate referrals and linkage to other services, as I mentioned earlier. So this is the minimum package of services that are expected to handle post-violence care for our clients. So we'll go a bit into detail as what's expected. Within 72 hours, what is expected? When they first come, emergency treatment of the life-threatening conditions. We do an HIV test, plus or minus PEP or ART, depending on what we find. Syphilis testing, hepatitis B testing, and a pregnancy test. As I mentioned earlier, STI prevention and management. Pregnancy prevention and management. This is including the teenage pregnancies. Caring for those that have come already pregnant. We know that as long as the pregnancy happened as a result of rape or defilement, they deserve special care. So let's ensure that they get that appropriate care. Mental health care, which is often neglected. Let's take them for counseling, but also psychological management. And follow-up, we plan for follow-up visits. Next slide, please. After 72 hours, there are a lot of services that we can offer our clients. We could still do an HIV test, plus or minus ART, syphilis, hepatitis B, and offer a pregnancy test. We can manage any medical surgical complications that might be there. And if the client happens to come within 5 days or 120 hours, we should still do a high vaginal swab for spermatozoa, because we know that spermatozoa is able to survive in the genitalia for about 5 days, 120 hours. So they still are eligible for a high vaginal swab. We should manage any STIs. We can do pregnancy prevention, provided they've come within 120 hours, or manage the pregnancy if they've come beyond that. Still offer mental health care and provide follow-up for these cases. So we do not send them back and say there's nothing we can do.
All right. We go to the fourth question, which is also a true or false statement. A very interesting one, actually. Police forms for medical examination of defilement or rape can only be signed by medical doctors and medical licentiates who are trained in SGBV management. True or false? Police forms for medical examination of defilement or rape can only be signed by medical doctors and medical licentiates who are trained in SGBV management. True or false? So we have a few seconds to poll. This one should be interesting because we have different sets of beliefs. So this should be interesting, and indeed the answering pattern is interesting. 30 seconds. True or false? Police forms for medical examination of defilement or rape can only be signed by medical doctors and medical licentiates who are trained in SGBV management. We'll end the poll at this point, and Dr. Bupe would do well to guide us who should sign these forms.
So I think for those who are aware or may not be aware, there is a new police medical report form. It was launched, I think, late last year, towards the end of the last year, and should have started being used, not only disseminated, but being used in our facilities. But for those who may not be aware, we'll just go through its contents. So obviously, apart from the name of the victim, the survivor, the first part will look at the complaint, the details of the injuries. But what's interesting now is that part C, we actually look for the details of the police officer. And this includes their service number, their rank, their formation. Why is this important? Sadly, in some of our cases, we found that our police officers were actually the perpetrators of violence. Some of them would actually end up abusing our survivors whilst in their care, whilst in detention. So because of follow-up and easy identification, we decided to make them accountable for this, and this is why their details are included there. Details of the examiner, the name and the title, so meaning anyone, whether doctor, medical licentiate, clinical officer, and nurse can sign here as long as you put your title and so long as you've been trained in SGBV management. The health center where you operate, and the details of the person present during the examination. This means that it is a prerequisite to examine in the presence of a chaperone. Do not examine on your own, lest you be accused of perpetrating the violence as well. So the details of your chaperone should also be there, and then your address and contact number. And if we look on the right side of the screen, most of us had trouble belaboring, describing the injuries that we'd see on people's bodies. We'd even use wrong terms. So this has been made easy by providing diagrams, illustrations, where you just simply shade in the injuries. You place them where they are. And if you look at the bottom half, we're looking at the anatomical transections of the genitalia, which will even make it easier for you to point out where these injuries were and occurred. This, for me, has been welcome because I think I was tired of always going to court with a big placard, pictures of anatomical presentations and illustrating in the courtroom, explaining what goes where. And sometimes we go with our laptops and have to project where these injuries are. So with the coming of this police report, this will make it much easier. Then after that, that's when you conclude by saying, I think the injuries are consistent or not consistent. So now that we've taken you through the basics of what SGBV is all about, I'd like to talk about challenges that we experience in the programming area. We're experiencing high levels of pregnancy again amongst our survivors, especially in the adolescents. There's a lot of teenage pregnancy. And where we're seeing a problem is that a lot of these teenage pregnancies are not being counted as SGBV cases, but just seen as on their own. So this is where we'll need the obstetricians, gynecologists to join in to the GBV teams so that whichever teenage pregnancies they see will be reported as sexual GBV cases, especially those that are under the age of 16. There's limited interaction between the facilities and community-based survivors. We're not interacting, we're not talking, and we're not providing referrals to and from each other. So there needs to be that interaction. The GBV program has come up with some new indicators. So we need to incorporate this into the DHIS2 so that we can be able to report on these right from subnational all the way up to national level. We're also seeing weakness in our justice system for survivors. I receive late night phone calls from magistrates, from high court judges, asking me to explain findings. What is this that you wrote? What is 5 o'clock? What is hymen? Please explain. So those are the issues that we need to bring about. Then I'd like to bring an issue about the National Technical Working Group for GBV programming. It is now moribund. It used to be in existence, but somehow has died a natural death. So this could also be a reason why we're not seeing that multidisciplinary management improving as we've seen. There's low reporting rates, high withdrawal cases, and very low prosecution rates, as I showed you from those statistics. And because of this, we have because maybe of our lack or inadequate indicators, we do not have data enough to inform decisions and to inform policy. So this is on a programmatic level, but what about for community level? Some people believe that there's a reduction in reported incidents. Has it really reduced? Or is it that maybe we've increased sensitization so people are more aware? Or is it that the perpetrators are not being punished, which is now discouraging survivors to come forth? Because they say, even if I report, the perpetrator will go scot-free, so why should I bother? And is because of this, has this given confidence to perpetrators to go ahead and continue abusing because they know that they will not be prosecuted? And also, we're seeing it's easier, quote unquote, for pre-court case settlement and out-of-court case settlement. I can't say enough how many times I've gone to court and I'm there alone. The family doesn't show up, only to find that they settled outside court. What are some of the reasons for late reporting? Most people still lack knowledge about our policies and they don't even know where to seek this help. For the younger women, most of them are consenting and don't believe they're being abused because they believe they're in loving relationships. And also they'll be granted certain favors. And we've seen this because of the rise of intergenerational sex and transactional sex. He's paying for my school fees. He's built my mother a house. So because of that, they don't believe it's assault or abuse. There's also self-blame. As I mentioned, the society will blame them. How could you? How could you go out for a drink? How could you get into his car? How could you go to his house? So self-blame would stop people from reporting. Stigma, ridicule, and discrimination. This is more common in the men because they'll be laughed at for reporting because men are expected to be strong or boys are expected to be strong. For women, it's more the concerns of the welfare of others. What will my family think? How can I tell my husband that I was raped by somebody else? What will my church think? So these are some of the challenges we're experiencing at the community level. So what is our way forward? When it comes to national level, where we do policy development and management, we must resuscitate the GBV National Technical Working Group. We need to have national policy guidelines for medical management of GBV so that across the board, the management is uniform, it's equal and equivocal, and it will be more accountable, and our health workers will feel better equipped. We need to conduct quarterly technical support supervision to strengthen the program. We encourage that the provincial points of cares for HIV prevention should have monthly meetings. This will improve the focus on GBV, strengthen its ownership, support GBV programs, and also provide policy implementation issues that can be brought forward to the national TWG. We must include GBV as a program agenda in HIV prevention. So for the next HIV prevention technical meeting, we will have the GBV program provide updates. That way there will be accountability, visibility, and focus on the program. And we also have to ensure that all healthcare workers are aware and oriented on all the GBV indicators and data reporting tools, and they should be made available. At sub-national level, what do we expect? Our health workers, of course, to be trained specifically in clinical management or medical management of GBV so that they respond appropriately and manage the cases appropriately. We also would like to see an appointment of GBV focal point persons at provincial and district and facility level. We need to develop locally derived targets for our facilities so that we know and we'll be able to provide checks and balances on our program performance. We also need to make sure that for those facilities that do not have, we must acquire and disseminate all the data collection and reporting forms and registers. We encourage monthly meetings for our TA, DSD, and community implementing partners so that they review and strengthen the programs. These monthly meetings must be held with their provincial focal point persons. But most importantly, we must promote and enhance community sensitization and engagement. This can be done by meetings and even training. There is actually a training for sexual violence against children, sexual GBV for community and traditional leaders. That is the end of my presentation. I hope it's been eye-opening and we will all take part in stopping gender-based violence in Zambia. Thank you.
Thank you so much, Dr. Musonda. We appreciate such valuable information that has come across to us. And I think the network is very, very happy with the presentation so far. And I'm sure there are quite a number of questions in the chat box. So before we turn to the chat box, I know with the poll questions that were shared, I think things came up. And we just want to redo those questions and see how what were the actual answers for these particular questions. Okay, so we'll share the first poll question, and yeah. You can go ahead and just relaunch it for me. All right, so Dr. Musonda, we have this poll question here. Sexual gender-based violence is any act of sexual nature when consent is not obtained or not freely given and involving all forms of intercourse. Let's just give them a few seconds to cast their poll again and see if we're paying attention to the presentation. So far, most people think it's a true statement.
I'm beginning to wonder if I managed to confuse the nation.
Yeah. Okay, so I think this is now how many seconds? It's about a minute now. Okay, I'll end the poll. So Dr. Musonda, run us through this one.
So the answer here is false.
Why? Why is it
That
false?
definition that we put there is for sexual violence. And remember, the key word was all forms of intercourse. I think we learned that in sexual GBV, it's not only limited to intercourse, but it's also other forms. We spoke about inappropriate touch and all those things. I think if you can take us to the slide.
This one needs a slide.
Yes.
Is this one here, right?
Here was the answer. That is not only limited to intercourse, but also includes inappropriate touch, all forms of penetrative sex, and all these other things listed. So that answer was false, because that definition was for sexual violence and not sexual gender-based violence.
All right, thank you very much. I hope network we are together. Hey, I know it can be confusing. So we'll go for the next poll. Are we able to do that? Yes. So the next poll is child survivors of sexual assault or abuse who always present with abnormal examination findings. Myth or fact? I like this question.
I like it too.
Myth or fact? I think most people think it's a myth. Dr. Musonda, what do you think?
At least, yes, people heard and learning took place. That I think it's true. It's a myth. This is something we often believe, but it's not true, because remember I mentioned that the healing process in the child survivors is faster because of the increased vasculature on their genitalia. That's one reason. Another reason is because of the size proportions. Most of the injury will be to the external genitalia as opposed to internal. So therefore you will not always see injury. And I think there was a slide that
There's
spoke
even
to
this
this.
slide here that talks about experienced non-penetrative child.
Yes, so that was data
so
that proved that.
There may not be actually an injury because it wasn't penetrative.
Mm-hmm.
It was this other form of sexual violence, inappropriate touch and all those things. This could be the other forms. Okay, too much learning today, too much learning. Okay, so the next poll question is this one. When a survivor of SGBV presents to a health facility 72 hours after an ordeal, there are limited services to offer, including examination, HTS, and counseling. Another very, 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 very interesting one. I think Dr. Bupe, you were asking tricky questions.
Sorry, I'm one of those mean examiners.
Yeah, maybe you could run us through. Okay, we have most people actually thinking, over 90% think it's false. It's a false statement. Just a few think it's true.
So that was a correct answer. It is false. I think there was a slide that said that there's a lot of services that we can offer somebody who comes after 72 hours. So instead of just turning them away or just saying, all we can do is do a test and see if you're HIV positive, there's other things we can do. And I think that was the list. We can test them. We can still do a high vaginal swab to check for spermatozoa. If they've come within 5 days, we can still manage the STIs, prevent the pregnancies, mental health care, follow up.
Very, very.
Anyone comes now, let them go.
No, we don't allow them. We have fun.
Thank you for joining us on Echo, but we request that you mute yourself. That would be great. Thank you so much. IT, help us with muting. Great. Okay, so we move on to the final poll question. See how people performed. Police forms for medical examination of fireman rep can only be signed by medical doctors and medical licentiates who are trained in SGBV management.
True.
True or false? Just a few seconds. We hear what people think. Okay, so I'll just end the poll here. Most people think it's a false statement.
And that is the correct answer. We took you through the new police form, which allows any, for lack of a better word, cadre of the medical fraternity, provided they're trained, to be able to put this in context and to be able to fill this form. And I think if you pay attention to part D, they ask for the name, the title, and all those things. So anyone, so long as you've been trained, can sign on the new police medical report. I know there's issues. Some people still haven't seen it. They're not aware of this. And dissemination still needs to be done on community sensitization. So this will happen over time, but at least we should be made aware of this.
And thank you so much, Dr. Mahuma, for having been with us today and supporting us in this network. As we now respond to questions in the chat, as well as any questions that the network may have. I think I can see already a question from somebody that raised the question. Was it Chatundu? Please go ahead and unmute and ask your question. No questions? Okay, so let me just run through some of the comments in the chat. So we have a question, we have a chat here. Thanks, Dr. Bupe. I would like more emphasis on the teenage pregnancies. How do we go about it without negatively affecting facility deliveries? And I know what they mean. It's like when we want to promote adolescents coming in for care. Is that somebody wants to make a comment?
Yes, this is Irene from Karingaringa.
Yes, Irene, please go ahead and make ask your question.
Good afternoon, thank you.
Nice presentation, thank you.
Thank you very much.
I want to find out what happens if you discover that the teenager who turned 17 yesterday, but she started antenatal and registered herself that she's 18. So what is the way forward on that teenager who got pregnant while she was 17 years old?
All right, thank you very much for that important questions. Very practical things that are happening in the facilities. We'll just ask you to hold on to that question as we get another hand And Tula, would you like to unmute and ask your question? Thank you.
Thank you so much. I appreciate this presentation. I was hoping that we're going to dive a little bit deeper into the mental health area, but this is very beautiful, and I appreciate your training to us. I think it has built our capacity. My quick question that I think one area is that the police system, I'll use this word in general, the police, the process of navigating through the police, use the police, not the justice, the police, can be intimidating for adolescents. And also sometimes you find that just that interrogation can be also a traumatic experience. As Rise Up under Charles Drew, we are exploring other methods of counseling so that even when an adolescent goes to the police, as they come back, you kind of desensitize them through that process so that they're able to face another day through that process. And I think you mentioned to say there are settlements which happen outside court or even before court, which should not be the case. And those are kind of pressures which are more driven by socio-economic stimuli from the facilities. But I hope that we can find ways, either through the safe spaces which are available, through DREAMS projects, as well as the Rise Up projects, to make sure that these processes are followed up, supported by social workers and different safe space facilities which are available. Yeah, it's more of a comment, but also just to see your thoughts around this comment. Thank you so much.
Thank you very much, Ntula. We do know that you do a lot of work with adolescents and faced with all those challenges that come to your space. So, Dr. Bupe, would you like to make mention of the first question? You discover that the age that they're presenting is with pregnancy, but probably they were actually defiled before they were in the period. And of course, you have to respond also as well in the other question here, which was talking about, we still want to make sure that our indicators for antenatal are also working. Mm-hmm. What we are providing an environment for adolescents to be attended to. Mm-hmm. But when we start talking about police, then it becomes a deterrent for them to approach. We have experts on the call as well. Dr. Sam Miti is on the call. We have Dr. Rokaya. We have Dr. Kuku. I'm not sure if he's managed because he had a meeting earlier. And we also have Dr. Lalik Banda, who's also been a veteran, passionate about this on the call. So please do go ahead. I will be calling on you to just respond to some of the questions that will be coming on the network. Yeah, but in the meantime,
Dr. Kuku is here, so I could make a comment at a later point, but I'm here.
Oh, great. Thank you for you managed to join us. Thank you so much. So, Dr. Bupe, maybe you could give a response, or we can ask one of the other experts on the call.
Okay, on the gynecological cases, well, in terms of teenage pregnancies and management, I wish Dr. Ketsi Lubea was on the call, but I will endeavor to answer. So the issue, okay, there's two issues here. There's the age of consent, where they can access certain services as an individual. Currently, there is an exercise to look at, to revise certain ages at which we should be able to access certain services, which should make it easier for people to access these services. But I think what we need to do is enhance the capability or the services offered in our adolescent-friendly, youth-friendly spaces. Because if this person would have to access these services where it's friendly and where we have designated VSU officers or police officers who are there would be a way they would handle the cases without making it look like it's punitive and less discouraging. So I think it's about enhancing the performance or the services that we offer at the adolescent-friendly spaces, or providing appropriate linkages once one is found. How are they handled as a special, quote unquote, special case? Because under the GBV program, we do have special considerations for adolescents and how they should be handled differently from an average case. So I think that's what I can say on this one. I don't know if any of the other experts have anything to add on this. Dr. Miti?
We can ask Dr. Miti to come on. Dr. Miti, please, you can go ahead and mute yourself.
Thank you very much, Doc, and Dr. Thank you for this wonderful and very enlightening presentation. There are a number of things that have come. Sorry, I think I'm not unmuted. I hope everyone can get me very well. Thank you very much, Dr. Musonda, for this beautiful presentation.
Thank you.
Okay. Yeah. So I want to say that the 17-year-old that has been, that I think sister was making reference to, and they're coming to the clinic and they have registered to be 18 and so forth. I think there are a number of things that will need to be determined. First of all, according to our law, in terms of child sexual abuse or defilement, it's below 16 years. Anything above, really, if there was consent, may not qualify. But that again being put into context, because remember, we are talking about sexual-based, gender-based violence. So we need to look at this adolescent, in as much as they may be above 17, above 18, or they may be even 19, or even any adult. If consent was not given, then they need to be considered separately. But assuming that this was a consensual relationship and she has fallen pregnant, we need to continue offering the other services, the antenatal services and the comprehensive antenatal care that they need to receive. I just wanted to just add on and emphasize what Dr. Musonda talked about, the police forms. The form that we currently use, or most people are familiar with, the ZP form 32B. Actually, we have a new form that was gazetted, and the gazette notice was published in the government, at the government printers, essentially mandating this particular form to be in use. And the police have it, and it's, I think, almost 2 years now or so, if I'm not mistaken, that this form has been legal. However, there's been a bit of a lag, like Dr. Musonda has said, with publicity and also training and orientation. But I want to suggest to this fora and Dr. Musonda and the team that we can actually use this ECHO platform one of these days to actually share this form, because it's available and people can use it. And among the things that this form brings on board, which Dr. Musonda has highlighted, is the very fact that you have this pictorial evidence that you can be able to use to document things, and which is very, very key. My contribution really that I want to make is on the safety of the survivors, especially when the abuser is known to the patient. Okay, this can be an abuser who is probably in the same home or in the same environment, and the child or the adolescent has come out and garnered this courage to come and talk about this abuse with the healthcare system. We are actually mandated to ensure the safety of this patient, including bringing on board other important stakeholders such as the social welfare and the child protection unit of the Zambia Police, or the GBV unit, the victim support unit of the Zambia Police. And I think it is very, very key that we do that. I think I'll end there for now, but if opportunity allows, I can also add on later on about the, I saw in the chat box about examining a child who has had abuse for cervical cancer screening, but maybe I can only come in later. Thank you.
Thank you so much, Dr. Miti, and very, very profound statements there. There's another question here. What do you do to a case of sexual violence where the client is not comfortable being examined in presence of another person being present? So I've seen Dr. Rokaya. Are you able to pick that question, Dr. Rokaya? I know your clinic is quite busy this afternoon, but I've seen you've joined in. Are you able to pick that question?
Yeah, I think anybody else can take it up. I'm with the client.
Oh, okay. All right. Thank you so much for giving us response.
Dr. Kosa, can I speak? This is Mr. Gasoka. I raised my hand. Now the hand is tired.
It's very tired, eh?
The hand is tired now, Doc.
Mr. Gasoka, go ahead.
Yes,
go ahead.
There was a question on. First of all, thank you very much, Doc. Is it Dr. Musonda? Thank you very much for the presentation. I have enjoyed the presentation. So there was a question on if a client comes for antenatal today, she may be above the age of 16, but when we calculate the pregnancy, the sexual activity took place when she was underage.
Yes,
now,
yes.
Yeah, in law, there is something we call the statute of limitations. This one, it guides us to say there is a time frame within which an offense can be reported. So it simply says that if an offense is committed at a particular time, you have a limited period of time within which you can report and that person can be prosecuted. However, the statute of limitations does not cover crimes such as murder and GBV. What this means, therefore, that even if someone kills a person today, 2021, 50 years later, 2071, we can still prosecute that person. Same applies with cases of GBV. So if a person presents to your clinic at the age of 20 and says, I was raped at the age of 15, the law does not say it's too late. Those matters can still be prosecuted. So in the antenatal setup, therefore, if a woman presents or a girl presents that with a 6 months pregnancy, and you can tell that the time that this sex occurred, she was below the age, that is still a matter that has to be reported, and we do our part to ensure that such cases are prosecuted. Whether there's a conviction, I share the frustration by the presenter, whether there's a conviction, or whether the police do not prosecute the matter, I think for us that is beyond us. But for us, as healthcare providers, we are not allowed to say it's too late, you are now old. No, it doesn't apply. Thank you very much.
Very, 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 very critical information that you brought up, Mr. Kasoka. We appreciate it. Okay, thank you so much. I know I'm told St. Luke's had they had a question. So please go ahead as we find someone to respond to this one. St. Luke's.
Thank you, Doc, for the good presentation. We just have a question here. As HNP nurses, are we able to be trained as GBV in that category? And if yes, how can we access this training and where is it? Thank you.
Okay.
Dr. Mumu, you want to respond to that one?
Yeah, sure. So for these trainings, I'm privileged to be one of the trainers. I was trained in 2019 by Dr. Bupe, Dr. Katie, and Dr. Ziambo. So early this year, we started training Lusaka province. And I'm told by the coordinators that this training is going to be extended outside the province to involve other areas as well. So this is a matter that the province is taking very seriously. And I know that these trainings are going to keep going, especially that we're starting a new fiscal year. So obviously these trainings will start to involve a lot more people because now, for those that have looked at even the new dashboard, you will see that even GBV is an indicator, with targets that have been given. So definitely this training will be available to a lot more people because there are trainers that have been trained, and these trainers will go out there and train more people. Thank you for that one.
Thank you for raising that concern. That's actually one of the way forward that we presented in the presentation. You see it at the sub-national level. So this is something that as provincial health officers and implementing partners, I know the funding agencies have directed resources towards that. And so with your implementing partners, provincial health officers, this should be able to be cascaded down to everyone, and all it includes the HIV nurse practitioners. Thank you. Dr. Banda, I would like to hear from you all the way from Katete. There's a question here saying about a child who refuses to be examined by in the presence of a chaperone. I don't know if you can make a comment about that. Dr. Banda.
Good afternoon, everybody.
Thank you. We can hear you loud and clear, Dr. Banda.
Thank you. Nice presentation, Dr. Musonda. There, I was following right from the beginning. Well presented and everything very clear. So about, there's a few comments about the form first. I've had a lot of calls, including from Mr. Sampa there at UTH, regarding the use of the new form 32B. So this form had a gazette notice, yes, given, but there were a lot of mistakes. Actually, what happened was there was a meeting that was held, which was chaired by the Office of the DPP, that is NPA, and then attended by judges and the health profession. And it was found to have certain things that we needed to edit, to correct. So when the correction was done, at the time of submitting for gazette notice, the old one, which was not edited, is the one which was submitted. The one which was edited was not submitted. So it is very difficult in the current form to use it. So a lot of people are finding challenges, a lot of repetitions and a lot of mistakes in that form. So with the VSU office at Zambia Police, it has been agreed that we hold a meeting. They have already found a sponsor to have that meeting to edit the form so that when it is finally, so what was distributed is actually not the correct form. It's very difficult for people to use it. So that meeting will be very soon, maybe in the next couple of weeks, it will be held. The final corrections will be done and circulated for people to make comments. And the final version taken for printing and redistribution and the final gazetting. Now, who's supposed to sign it, like what has already been said? There are some people, you know, there's a high turnover of staff in the Ministry of Health. So people will be trained today, they attend a workshop, after that they leave, or they get promoted, or they move to another area and things like that. And then you have people who are in the stations where they are not doctors and they have not had a specific training on GBV. Can they sign this form? The answer is yes. They should sign the form, even if they have not received specific training in terms of GBV. What they have seen, they are witnesses of fact, so they can actually write on the form. There will be limitations, definitely, and there will be a few disadvantages, but that will be a few cases that will happen, but we can have them sign. When they sign one or two, if there's an opportunity for them to get trained, they can get trained. So I think we are all of us coming from that background. The reason is because even the trained ones, a few that have been trained, may not be there. So the purpose of coming up with this form is to lessen the burden that only when the limitation that only when the doctor is there, that's when the form can be signed. So that's what I wanted to make comment on the form. Coming to the child who does not want to be examined in the presence of a chaperone. This is age specific. So according to the laws of assent and consent, if a child is less than 2 years, this child can be forced. The examination can be forced on the child. So the child can be restrained and examination can be done. in our environment, if the child is 7 years and above, we need to obtain assent. If the child says, no, I don't want anyone else to be there, there is of course conflict between what the child is saying and what the guidelines about examination say, that you should not examine alone. So what do we go for? We go for what the patient is saying. So if the patient is not comfortable to be examined in presence of another person, we need to ask them whether we can examine with a different chaperone, not the parent. Maybe the patient has a problem with that particular chaperone. Can we look for another one? But if the child still insists that, no, I don't want any other person, I just want you. One of the ways to do it is probably to document that examination, maybe via a video or so, but we need to go ahead and examine the patient. Of course, there is assent there. If it's a patient, an adolescent who can write, they need to put that in written, that this is what the wish of that patient is, and it should be signed. If it's a child who is in grade 7 or grade 8 or so, they can write. So this is what you want. Yes, this is what I want. So they'll be meant to sign, and then the examination can be done. So at the end of the day, what is important is acting in the interest of the patient. So if there's evidence, the patient, the doctor is acting in the interest of the patient through documentation and signing. That is okay, it can be done. As long as there is no ill intention. It's a difficult issue. But the other one is that if it's not an acute examination where we are rushing for something, we can send this child for counseling if the child can be cancelled, if it's the age that can be cancelled. If the child is cancelled and told that the examination is well done when there is another person to witness, and through counseling they yield to what is the correct procedure is, that would even be better. But at the end of the day, we need to get evidence. We need to document something. Those will be my comments, Dr. Zambo and Dr. Musonda. Thank you very much.
Valuable comments, Dr. Banda. We appreciate you joining us, and just to give your technical expertise on this, and especially on the forms. And I see you've also addressed the issue of who should be able to sign. There was a question in the chat. I hope, Chancellors, you've seen that that question has been responded to. And we do have a few more questions here. They were asking that why is voyeurism and child pornography, why is it also sexual violence? Why is it considered as sexual violence? Maybe you can respond to that, Dr. Musonda.
So what that is that it's exposing a child or an unsuspecting person to explicit content. So for children, it's sexual abuse because in that exposure, children have the psychological ability or psychological affinity to mimic what they see. So the next thing they'll want to do is practice what they saw. Obviously in total oblivion, whether it's bad or good, but because of what they saw, they will go and repeat it. And to a person who might take advantage of that, it then perpetrates the sexual assault or abuse. So just the fact that you're exposing the child is violence in itself, because you do not know what is happening psychologically to the child and what results will come out thereof.
Thank you so much. There's another question here. Male adolescents and males should not be neglected in this area. And so how are cases of SGBV handled in males? Barbara says she could have missed this section. I don't know if you're able to speak to that.
Yes, so basically the management is the same for both boys and girls. The only thing I will mention is that it's more difficult to see injury in boys, especially those who are uncircumcised, because of the protective function that the foreskin would provide. So because of that, injuries are almost always very hard to pick up. But otherwise, the management is the same. The procedure of all the services is the same. And I will agree with you or have note that in my years of practice, as the years are progressing, we're seeing more boys becoming abused or maybe coming out more. And sadly, in this age, it's mostly been maids who've been the perpetrators. Taxi drivers and coaches for sports activities have been the main perpetrators. So it is actually becoming more common now to have boys being sexually abused.
Okay, that's a very alarming, indeed, information. So are there any hands that I can't see here? Dr. Miti would like to make a comment? Dr. Sam Miti, you can unmute and make a comment.
Thank you very much, Dr. Banda and Dr. Musonda. I just wanted to add on what
okay, so Dr. Okuku, I don't know if you have any comments so far that you would like to just discuss, because I can see here somebody's raising questions as to why do we have low prosecution, why the prosecution rate is way less than what has been reported. And all these, there are questions like, how do we get to have more of the staff trained in SGBV management? I don't know, Dr. Kuku, if you can respond to that. Thank you.
Thank you very much. And thanks for all the presentation and the contributions so far. Zambia actually has adequate tools for legal prosecution of GBV cases. When I say adequate, I don't mean in terms of number, but I mean the number in terms of different types of tools that already exist. The challenge we may have may be implementation. But the Anti-GBV Act, for example, is very comprehensive and provides protection for survivors. You also look at the Police Act that prescribes or recommends the setup of victim support units in all police stations. You have the Zambia Penal Code as well, that also has language on the prosecution of cases. And in recent times, a few years ago, Zambia started using the fast track courts, to ensure that GBV cases are expedited. In addition to that, we also have other measures like the one-stop centers and the facility-based clinical management. But one thing that has been lacking, and I think Dr. Musonda did mention it at some point, is the lack of forensic evidence. And that has also led to the low levels of cases being prosecuted. Because when you get in the final analysis, people will ask you for evidence. And if you cannot provide it, it's going to be hard to move beyond that point. So the good news is that PEPFAR has supported the Ministry of Home Affairs to set up a forensic lab. I was there in person a few days ago to see it, and soon it will be ready for use, and I'm sure everybody will get to know about it. And with that facility functional, it will become a lot easier to generate forensic evidence to prosecute some of these cases. The other thing that I want to say is on the importance of community programs in mitigating GBV cases. I know a lot of the discussions we've had so far, and even Dr. Musonda's wonderful presentation focuses on facility clinical responses, the majority of it. But as you all know, GBV occurs in the community. And unless you have adequate community strategies to manage it, facility-based responses will be significantly inadequate. In the chat, for example, you have the question, somebody asking a question on how religious organizations can be engaged in the GBV response. And that's true. That is because the community is critical. The police units and the victim support units are in the community. You have churches in the community. You have schools in the community. You have shelters in the community. All of these are entities that need to be mobilized in one way or the other, either in the form of training, sensitization, information dissemination, to also participate in the response to gender-based violence. So we need a multi-sectoral response, and the existing tools that Zambia has can be strengthened. We have quite a lot of things that I think can support and help the mitigation of this issue. But the challenge is sustained implementation at high levels. Over. Thank you.
Dr. Kuku, thank you very much. I appreciate your bringing up the aspect of community sensitization and engagement and using those structures within the community to fight GBV, because that's where the cases happen. And that's a very critical component to the GBV response. And here already I can see a statement on how to kind of categorize early pregnancies below the age of 15 years and not reported as GBV by the guardian. I think all this is just about sensitization and information around this particular response. Okay, so I think most of the questions here have been answered. We have a question here asking, are police supposed to actually drop the cases? I'm not too sure who can respond to that one. Dr. Musonda, would you like to speak to that?
Maybe Dr. Banda would be
Dr.
the
Banda,
best person to help us.
There's a question here saying, police, can they dismiss a case?
Thank you for that. Very important question, very practical question. So from the last report, the other thing I didn't mention, I'm very glad you quoted that survey, Dr. Musonda. We need many of such kind of reports. They don't have to be a full research, but we just need to be informed on what is happening. So the last survey that we had, we used to receive patients. So assuming that we receive referrals from the other areas, 100% to say the facility at UTH, the one-stop center. Now, out of those, we send 90% of the reports to the police. From the police to the court, what used to go to the court would be about 20%. So meaning that 70% of the cases were dropped at the police. Then from the court, what they would prosecute would be about 12%. And then from the 12%, the outcome will be around 5% in terms of convictions. So we lose about 7% from the court, about 70%, 10 times at the police. Now, what are the circumstances? There are factors related to the police service itself, in the sense that they are usually not well equipped to investigate the cases. So they themselves feel inadequate to take the case to court, to get the docket and take it to court. So they will drop the case. Second is that there are issues of the relatives. Usually you find that the person who is a suspect will try to negotiate to have the matter settled outside the court. So they will pay something. The family knowing very well that even if this person is taken to court and they are convicted and they are imprisoned, there will be no benefit to them as victims. They would rather settle for outside court settlement because they will get something out of it. And all they will do is they will not go back to the police to have the issue pursued. So the prosecutor, the investigating officer will try to look for this family. They will not find them. So they kill the case themselves. That is another reason. But also we can't rule out some other factors. For example, how do we package the evidence ourselves as health workers? The police may feel inadequate that, okay, this case, the medical report says not consistent. So on what basis am I taking this case to court? They will drop it. There are also suspicion of corruption. It can happen. The suspect can actually bribe the family, they can bribe the police. And sometimes a few maybe court clerks or something like that, it can happen anywhere. But here, I think the focus of discussion is the police. So can they drop the cases? Yes, they can. And the victim support unit, lastly, is that they train in counseling. So the police are supposed to maintain a law and order. So from their perspective, it's not every case that should go to court if they think they can offer some solution, as long as that solution is acceptable to the family and is satisfactory. So for example, if the person who raped a child or who defiled a child is not known, on what they can take the case to the court, but who is the accused? There is no accused. So they may drop that case. So where the evidence is weak, the police may drop the case because they don't want to go to court and then they lose the case unless there are proper investigations that are done. I think that's the answer I can give. Thank you very much.
Dr. Banda, thank you so much, as always. And, you know, this is a very, very, very interesting discussion topic. And I didn't realize that we've actually already hit 16 hours. We didn't even do any cases today, but we're almost running out. But I've seen that there's a hand from CDC Zambia. Is that Dr. Okuku? You would like to make a comment?
Yes, thank you, Dr. Jambo. I'm not sure, I joined at 3 after my other meeting, so I'm not sure if this has been addressed. But from experience, I have seen that sometimes when survivors of sexual violence, they go to health facilities, some health workers refuse to attend to them, stating that they must come with a police report. And I think that the legal tools or the guidelines that we have around how cases should be managed do not actually state this. I think it is the Police Act also that actually states that when a victim, a survivor of gender-based violence arrives at a health facility, or rather when they go to a police station, they get a police report. The Act actually says that with a police report, cases like that can get free health services at the health facility. But it does not state that when a client gets to the health facility, that health workers cannot provide emergency and urgent health care because the survivor does not have a police report. And since a lot of our audience here are health workers, I thought that this is an important issue to address. And I would appreciate comments from Dr. Banda and Dr. Miti and others here so that our health workers can be guided on this very important element. Over.
Thank you, Dr. Okuku. We already have Dr. Miti here. Please go ahead, Dr. Miti.
I know time is on there, but I'll be quick. So I think it's not the Police Act, but it's the Anti-Gender-Based Violence Act of 2011, which actually insulates or protects and guarantees that the victims of abuse, victims of gender-based violence access services free of charge in public health institutions, but also that the form is not a requirement. So we are mandated to provide the service as part of the ABC that we've been trained as healthcare workers. But after we attend to them, then we link them to these other services, including the police and legal services that are needed. So the form, the police medical form is not a prerequisite to attend to a gender-based violence survivor. We can attend to them, then have the medical legal issues follow through later. Thank you.
Very, very exciting and informative session that we have had. We hope we can have another session like this to deep down dive on a few issues. So I would want to appreciate our expert on the panel that we have had, Dr. Banda, Dr. Miti, Dr. Rokaya. We do recognize that your clinic was busy this afternoon, so it's fine. And thank you so much, Dr. Okuku, for the support in developing the materials and just being here on the call. We appreciate the network for having connected. You've asked very important questions. We hope that this presentation has cleared some of the myths and been able to sieve off and get some facts from the presentation. We want to appreciate Dr. Musonda for your diligence and the way you presented. Thank you very much. Dr. Malirwa, thank you very much for joining us here as a co-facilitator. I think that being said, we look forward to seeing you next week. We will be having another detailed presentation on smart care with the new forms that have been introduced. We just wanted to make sure that people, our healthcare workers, are exposed to the latest, to the new smart care forms that have been introduced. So we'll see you next week. Do have a lovely week. Thank you very much.
Thank you, Dr. Ziambo, Dr. Musonda, and the team. And until next time, bye-bye.
Yeah, bye.